लगा
बहुत दिन के बाद
हाँ
साल बाद
कैसा है
बरा है
कुठे शिवाजी पार्कला ना
और शिवाजी पार्क शुश्रूषा धन्वंतरी
ओके
ज्यादा घूमने का नहीं ज्यादा घूमने का तो आईएमए में आता है खाली little far that's all you go to which places
I have my own small setup in चेंबूर
okay
आणि चेंबूर मध्येच फिरतो एक झेन हॉस्पिटल आहे रॉयपट
हा ते माहिती आहे झेन
तिथे ऑपरेट करतो नॉर्मली
ओके
आणि आरसीएफ हॉस्पिटल आणि गोदरेजला जायचो आता कोविड नंतर अजून गेलो
ओके
चालू होणार आहे टाइमवर
हाँ should
ओके
that's why I joined actually me I came from OT then I realized कि I can't reach IMA now instead of that I said I will log in from my house easier
ओके
yeah Dr. Jitesh you have muted yourself
Yes, good afternoon.
yeah should we start
We can start. Dr. Anil was just about to join. He's also
Anil has not joined?
No, he is not joined.
Good afternoon.
I was checking.
Okay.
Yes, good afternoon, Dr. Kajal.
I'll just sit on for any technical assistance.
Dr. Narurkar, my father was GP at Chembur, Dr. Dhanraj Saetia.
Yeah, I knew him.
Now my brother is there, Sunil Saetia.
Yes. Sunil is a radiologist, no?
Yeah, my brother, yeah.
Right.
My father was also there.
I know.
Sir, here just I am checking the try to share a screen. So just give me a minute.
I think we can start if Dr. Anil is not coming online.
More than 300 delegates have joined. So I think the number of delegates is beyond 325, 328.
Is my screen is visible, sir, to you?
Yeah.
Yes.
Yeah.
No, sir. Okay. Thank you, sir.
Zoom link से आपको मेल किया होगा
Dr. Girish?
Yes.
Shall we start?
Yeah. I'm all set.
Yes. So now you have to welcome.
Yeah. So good afternoon, everybody. Myself, Dr. Girish Lad, Secretary IMA Mumbai branch. On behalf of IMA Mumbai branch and headquarters, we are going to start a webinar on allergic rhinitis. As you all know, that once upon a time, if you want to bunk anything, office, you used to always say, "Kuch nahi yaar, sardi ho gaya." But nowadays, after COVID times, people are very scared. They will never mention sardi hua, khasi hua. They will always try to give some other reason why you are bunking. But anyway, the allergic rhinitis is a element which really causes concern to the patient because it comes again and again, and therefore today we are supposed to learn the trick of the trade to get rid of this kind of suffering and know about the allergic rhinitis in detail. So we have got good speakers who will enlighten us about allergic rhinitis. Now I request our President, Dr. Jitesh Mehta, to give his presidential address.
Yeah, so good afternoon, everybody. On behalf of IMA Mumbai branch, I welcome all of you to this webinar, which has come to us from the IMA headquarters. A very important topic is allergy, and that also allergic rhinitis is focusing on a very particular aspect of allergy. So it is said that anything under the sun, including the sun, can cause allergy. So this makes this topic so vast, and it is going to be very, very interesting to listen to our three speakers, esteemed speakers of today. So friends, a brief recap of our activities that is going to happen in the next few days. So as you know, March is ending, and when April month starts, we have the installation of the new president. This is my last month. 10th of April is our installation program in the evening, and our chief guest will be our national president, Dr. Sajanand Prasad Singh. Dr. Anil Awad is going to take over after me. In the morning, we are going to have a webinar. We are going to celebrate the WHO Day, and we shall be having speakers talking on WHO theme and many other topics also. So, of course, the lockdown is like easing up, and we are going to come into pre-COVID times, and I'm sure there will be more of physical CMEs, but the webinar culture will, I think, remain, and because people are so used to it, and we can cater to a large number of audience. So that is one big advantage of the webinar, and I'm sure we will be continuing webinar as well as physical on side by side. So let's have a nice talk just now, and I hand over the mic to Dr. Anil Awad, who has just joined with us. Dr. Awad, can you please take over?
Dr. Jitesh, sorry I joined late. There was no link with me. Anyway, we are beginning.
There is some problem with your Wi-Fi, or the voice is not clear.
Voice is not coming.
No, it's not. It's drooling, like it's lagging behind. You got a slower speech just now.
Can you hear me now? Can you hear me? Jitesh, can you hear me?
Yeah, but very faintly. There is some, I think your signal is very weak.
This is sounding like whispering pectoriloquy.
For me, it was a slurred speech, you know.
How can you hear me?
Yeah,
Yeah.
better. Yeah, better.
Friends, today we are starting with our webinar on allergic rhinitis. We have with us Dr. Narurkar. Introduce Dr. Narurkar. Dr. D.M. Narurkar is consultant ENT surgeon practicing for more than 30 years. He primarily practices at Narurkar ENT Hospital, Chembur, and is attached with Jain Multi-Speciality Hospital, Apollo Spectra Hospital, and RCF Hospital. Dr. Narurkar is an alumna of Lokmanya Tilak Medical Hospital. He has presented many papers in regional and national conferences and moderated many sessions in conferences. Today, he will moderate the whole session on allergic rhinitis, as well as he will give a brief introduction about the topic, as well as the speakers who are going to talk to us in this web CME. I request Dr. Narurkar to take over the charge of this session.
Thank you, Dr. Awad.
Yeah.
Good afternoon, all doctors. Welcome to the interesting webinar on allergic rhinitis. I wish to thank IMA Mumbai and Sanofi India for giving me this opportunity to moderate this interesting session on allergic rhinitis. So first, I will give a brief introduction of this topic. Then the two speakers, Dr. Vikram Khanna and Dr. Nitin Gupta, will make their presentations. And in the end, we'll grill them with some pertinent questions. So if you have any questions, you can please forward your questions and we will be asking the specialist on allergic rhinitis to answer them. So a brief introduction of allergic rhinitis. As you are all aware, the global incidence of allergic rhinitis is on the rise in both adults and children. The Western countries have higher incidence than the developing countries. The probable reason for this is better sanitization, better hygiene, proper nutrition in childhood. So all this helps to reduce the incidence of microbial infections in childhood. And thus the Th1 pathway, which is concerned with destroying the invading bacteria and the parasites in our body, remains dormant, whereas the Th2 pathway, which is involved in allergic response, remains active. Exactly reverse happens in developing country like ours. There's a high incidence of microbial infections in childhood, which keeps the Th1 pathway hyperactive, and thus the Th2 pathway, which is concerned with allergic responses, remains dormant or inactive. However, nowadays in our country also, especially in the metropolitan cities like Mumbai, we are seeing a higher incidence of allergic rhinitis in children, probably because of better living conditions now. All these atopic allergies are immune responses mediated by IgE antibodies. Several longitudinal studies have shown that people with high IgE levels first have allergic dermatitis in childhood, followed by some food allergies, and then allergic rhinitis, and finally asthma. So this progression of allergic diseases is what we call as the allergic march or the atopic march. Generally, this allergic dermatitis and food allergies either reduce significantly or disappear as the child grows. But if allergic rhinitis is not adequately treated, then a high percentage of these patients progress to asthma. So it is important as clinicians that we identify patients with allergic rhinitis, treat them adequately, and stop this progression of allergic march. In the past, when I started my practice, we used to tell all allergic rhinitis patients that I can just control your problem. I cannot cure your problem. Okay. So it was very difficult to answer a question when the patient would ask me, "Main theek hounga?" It was very difficult to answer this at that time. But now, with all the new drugs that are available, newer surgical techniques, and various vaccine therapies that are available, it is possible to definitely increase the remission period significantly, and thus improve the quality of life of these patients and reduce the financial burden in medicinal costs. So today, definitely, with so many facilities to treat allergic patients, we can say that for a few years at least, we can keep you free from allergies. But definitely with whatever we do, the allergy definitely is going to come back sometime or the other. Okay. So as far as allergic rhinitis is concerned, it typically occurs in 4 phases. The first phase is the sensitization phase, in which a small pollen grain enters the nose. The mucociliary pathway is not able to clear this out. So that innocuous small pollen grain remains in the nasal mucosa. Our immune system is not much bothered about this because it is not a bacteria or a fungus or a virus there. So it sends a cell, a dendritic cell called a antigen presenting cell, to pick up this pollen grain, which is then transported to the nearest regional lymph node. There the naive T cells get activated, and because it is not a microbial organism, the Th1 remain dormant, but the Th2 pathway becomes activated. This Th2 cells then secrete some cytokines, interleukins, and they also stimulate the naive B cells to start producing IgE antibodies. So these IgE antibodies then go to the nasal mucosa again and attach to the receptors on the mast cells. So the sensitization process is completed when these IgE antibodies get attached to the mast cells. The second phase is the early phase of allergic rhinitis. So this is when the same pollen grain enters the nose for the second time. So when it enters for the second time, it goes and attaches to the mast cell and bridges the gap between two adjacent IgE cells. So when this linkage, cross bonding or linkage occurs, the mast cell degranulates and it starts releasing histamine, prostaglandin D2, and some leukotrienes also. So histamine is the main chemical involved in this early phase of allergic rhinitis, which results in watery rhinorrhea, sneezing, itching, and some amount of nasal obstruction because of the prostaglandin D2. So this early phase occurs immediately after exposure to the pollen grain, and it lasts for a short duration. The third phase is the late phase. In this phase, there is ingress of inflammatory cells, the eosinophils, neutrophils, basophils, into the nasal mucosa. They set up an inflammatory response in the nasal mucosa, and it produces nasal obstruction. So in the late phase, the main symptom is nasal obstruction. The late phase occurs a few hours after the pollen grain has entered the nose. So when I studied ENT, at that time, allergic rhinitis was limited to these three phases only. It was considered to be a local disease. But now we know that there is a fourth phase also, which is a systemic activation phase. For some reason, when the pollen grain enters the nose, the bone marrow also gets stimulated, and it increases the production of precursors of eosinophils and basophils. And these cells are then transported to the site of allergic reaction, where they activate and form eosinophils and basophils. So this is probably the reason why the mucosa in allergic rhinitis patients remains in a permanent inflammatory, minimal inflammatory state. And these patients are always in a hyperactive state. So minimal stimulation also elicits an allergic reaction in these states. So with this, I think I have given just a brief introduction to allergic rhinitis, how to diagnose allergic rhinitis, how to treat allergic rhinitis, what are the different modalities available for treating this, will be discussed by our two eminent speakers. So I request Dr. Vikram Khanna to take the mic. I'll just give a brief introduction of Vikram Khanna. Vikram Khanna is in private practice in Mumbai since 2004. He is attached to Global Hospital, Raheja Hospital, and Lion Tarachand Bappa Hospital. He is a member of the governing body of AOI and has been invited as a speaker in various regional and national ENT conferences. So Vikram Khanna will talk on A to Z of management of allergic rhinitis. Over to you, Dr. Vikram Khanna.
Yeah, good afternoon, everyone. I hope I am audible. Am I audible
Yes,
clearly?
yes, you are audible. Yes.
Yes,
Yeah.
sir.
I will need permission to share screen. Is the screen visible?
Yes, sir.
Yes, yes.
Is the first slide visible?
Yes.
So my topic for today is the A to Z of allergic rhinitis management, a comprehensive interview, where I will be trying to cover all the aspects in a brief manner because the time given to me will not be sufficient to give a lot of details. So let me get started. But before that, I would like to thank the Indian Medical Association Mumbai branch and the event education grant providers for today's event, that is Sanofi, for giving me the opportunity to present my views and share my experience with you all. And Dr. Narurkar, you have been a very cooperative and a humble senior. Always we have depended on you for any help. And thank you for your kind words of introduction. So as we can see in the slide, it is one of the allergy is one of the major allergic diseases that one can have. The other being asthma and urticaria and allergic conjunctivitis. The burden of allergic rhinitis is enormous, constituting almost 55% of all the allergies, and worldwide it affects almost to the tune of 25. And in the pandemic, that has increased to almost 30% of the general population. Incidence of allergic rhinitis in India is around 30 to 35%. These are slightly old slides. 2017, 2022 figures are around 35 to 37%. And we have seen a consistent rise in the trend of allergic rhinitis in Indian children because of the hygiene hypothesis, where the cleaner you get, the more allergic you are, the more infections you have, the less allergic you are. So we are all becoming a more hygienic society, and now with all our hand sanitizers and we have our vacuum cleaners and AC houses, we are, and mineral water, we are becoming more allergic than infectious. Aria classified allergic rhinitis depending on the symptom duration and severity into 4 phenotypes. So depending on the duration, it is either intermittent or persistent. This was called seasonal, and which is now called intermittent. Depending on the severity, it is either mild or moderate to severe. The criteria are shown in the slide. People who want can take a photograph. So there are 4 phenotypes: intermittent, moderate to severe, similarly persistent mild, persistent to severe. So there are 4 phenotypes, and the treatment of all these 4 is different, as I will. Type of rhinitis.
Your voice is not clear, Dr. Vikram. Your voice is not clear. Intermittent voice is breaking.
Am I audible?
No,
Audible?
not clearly.
Now am I audible?
You say a few words. Let me see.
Am I audible better now?
Slightly better, yes.
So,
No, no.
just a minute.
Actually, your voice is breaking, sir.
You're not audible.
Yeah. Now am I audible? Audible now.
No, voice is.
Yeah, just give me a minute. Just give me a minute.
Khanna seems to be logging from some other point. Dr. Narurkar, are you there? Yeah, you can just take over till the time he joins again.
Okay.
Yeah.
So can we go ahead with the second speaker, or what do you want me to do?
Yeah, we can start if you.
Huh?
Yes, yes.
We'll go with the second speaker.
Yeah,
Yes.
okay.
I think he's coming online.
Hello. Yes.
Is he coming?
Hello. Yeah.
Yeah.
Dr. Vikram, are you there?
Dr. Nitin Gupta.
Okay.
Okay,
Yeah.
let us start.
Welcome, Dr. Nitin Gupta.
Yes.
So I'll just give a brief introduction of our second speaker. We're having some problem in connectivity with the first speaker.
No problem.
Instead of wasting time, let us go ahead with our second speaker.
Yes, yes.
So Dr. Nitin Gupta is an alumni of BHU. Now he's in private practice in Mumbai and works from Vokad Hospital, Global, Bhatia and Bridge Candy hospitals. He has received training abroad in endoscopic sinus surgery and ear surgery in USA, Italy and Germany. So Dr. Nitin Gupta, please take over the mic and go ahead with your presentation on appraisal of the various therapeutic techniques available for managing allergic rhinitis.
So Dr. Vikram is joined again.
Am I audible now? Am I audible now?
Yeah, you're audible now. Yeah.
Clearly?
Yes.
Yeah, much better. Yeah.
Yeah. So I have gone, changed the Wi-Fi connection.
So 1 minute, huh? So Nitin Gupta, Dr. Nitin Gupta.
Yeah.
So
Yeah.
you'll have to remove the screen sharing because Dr. Vikram Khanna is coming back. Yeah, that's fine. So Dr. Vikram Khanna, please go ahead.
Yeah. Is my slide visible now?
Yeah.
Yes.
Yeah. So we were coming to the etiological classification of rhinitis. So as shown in the slide, IgE mediated, that is allergic, the autonomic variety, the infectious, which is mostly viral, and the idiopathic, of which the allergic and the autonomic are the dominant ones. As written in the description, allergic rhinitis is an IgE mediated inflammation resulting in eosinophilic and Th2 cell infiltration of the nasal lining and further classified as intermittent or persistent as per the Aria Guidelines. The autonomic rhinitis are of various types, that is vasomotor or idiopathic rhinitis, drug-induced, that is rhinitis medicamentosa, which happens with the nasal drops, persistent use. Hypothyroidism can also lead to autonomic rhinitis, hormonal changes, especially during pregnancy, and non-allergic rhinitis with eosinophilia syndrome, that is called NARS. We also have a type of rhinitis in the elderly known as senile rhinitis, which comes under the autonomic variety. So, the slide is not moving. Stop sharing and start again. Yeah. So this is the mechanism of the initiation of the allergic response, where the Th2 response causes the B cells to release the mediators, which acts on the mast cells, basophils, and the eosinophils. Also, the Th2 induction causes the Th2 type cytokine production, which activates the effector cells of allergy, ultimately resulting in the release of histamine and leukotrienes. That is why antihistaminics and anti-leukotrienes have a role to play in the management of the symptoms of allergic rhinitis. So what are the symptoms? There are some definitive symptoms and there are some non-specific symptoms. So the definitive symptoms are watery anterior rhinorrhea, sneezing, especially paroxysmal, that is bouts of sneezing, especially in the early morning, nasal obstruction, itching in the nose. The eye may or may not be involved with redness of the eye, itching and watering. The symptoms which are not associated with allergic rhinitis usually are when it is a unilateral complaint, when there is nasal obstruction without any other symptoms like sneezing, itching, and watery nose. Mucopurulent rhinorrhea goes more in favor of sinusitis. Posterior rhinorrhea, that is post-nasal drip, is usually not associated with allergic rhinitis. Patients of allergic rhinitis usually do not experience pain or epistaxis. Anosmia is not there. Anosmia goes more sudden onset, especially goes more towards COVID. So, we were taught in first MBBS that, history is most important. So as per this slide, to diagnose, we have certain, cardinal signs and symptoms. The symptoms are nasal congestion in the form of sneezing, rhinorrhea, itching, post-nasal drip might be there in patients who have a lot of secretions, throat clearing, cough and malaise. Historical findings would be from the history, we would whether it's a seasonal type of a picture or it's a all year round picture. Is there any particular trigger, any animal or plant? Certain medications can give rise to rhinitis type of picture. Allergies, usually there's a family history, so we inquire for family history of either allergic rhinitis or asthma or both. And if there are any irritants like dhoop, agarbatti, because that makes it less allergic, more of a irritation and autonomic type of rhinitis. And any symptoms of upper respiratory tract infection like fever and all, which takes the diagnosis away from allergic rhinitis. In the physical findings, usually allergic rhinitis has clear watery nasal discharge. We may say pale pink swelling of the nasal mucosa or bluish because of the venous congestion. If the eye is involved, we see the swollen conjunctiva and the watery discharge. Scleral infection may or may not be there. Frequent throat clearing because of itching in the nose, allergy, shyness, and nasal crease. The nasal crease is because patients constantly rub their nose like this. So there's a transverse crease on the base of the nose. And we have to always rule out absence of a foreign body or purulence, which suggests an infection. So the diagnostic algorithm of allergic rhinitis is shown in the slide. It can be taken for reference purpose as a screenshot if people are on the mobile, where in chronic rhinitis, you do a nasal examination. If the history is suggestive of allergy, you go ahead and do a skin prick test. If it is negative, then you do the local, that is the nasal allergen test, where if it is positive, it is local allergic rhinitis. If it is negative, then it's non-allergic rhinitis. Similarly, if the skin test is positive, then you see whether the sensitization is consistent with the pattern of symptoms. If the patient is shown allergic to a allergen which is present all through the year and the patient also has symptoms all through the year, then it is positive correlation which confirms the diagnosis of allergic rhinitis. But if the skin prick test is positive, but there is no correlation with the nasal symptoms, you again do a nasal airway challenge. If the nasal airway challenge is positive, that means patient has local allergic rhinitis as well as systemic allergic rhinitis. If the nasal allergen challenge is negative, that means patient has mixed rhinitis. That is allergic rhinitis positive, but a element of vasomotor rhinitis also. So this is the treatment algorithm that we all follow. So there are recent advances in the form of nasal provocation test or the nasal airway challenge test. So it's a diagnostic tool that reproduces the mucosal reaction to a specific allergens, mainly dust mites. It is highly sensitive, specific, and reliable diagnostic assay for the local allergic rhinitis and occupational rhinitis. Certain people have occupational rhinitis where they are exposed to certain things at their occupation place, which causes sensitization of the nose and the symptoms of rhinitis. We also now have pollen challenge chambers, which where we can check for the pollen allergy outside the time of natural pollination. The exposure is controlled and uniform, and you have to adhere to the medication administration. It's an instantaneous and precisely timed method of checkup, and the symptoms are assessed based on the response of the patient. Also, we have allergen microarrays, where the advantage is that there is a parallel and simultaneous assays of more than 100 clinically relevant allergens with a small amount of serum. The disadvantage being that incidental detection of IG to unexpected allergens can be there, and the sensitivity is found to be limited. We also now have the basophil activation test or the BAT and the mast cell activation test, that is the MAT. They have their own applications and limitations. They require fresh blood samples. And serum samples can be used for MAT, but the limitation of MAT being that it is difficult to obtain mast cells from the blood progenitors, which need more time and specific. So these are more, as a research in the institutes rather than in mass practice. So the tests that remain common are we do the serum specific IG, not the total serum IG. Total serum IG can be high even in patients having benign prostatic hypertrophy and children having worms in the stomach. So serum total IG is not a test. We have to do serum specific IG. And of course, the gold standard, that is a skin prick test. We can also do nasal cytology by taking a nasal swab or a nasal scraping or a nasal lavage, where we see for the various type of inflammatory cells, that is the eosinophils, basophils, neutrophils, and goblet cells. And they give us, different lot of differential diagnosis, and hence we can manage the allergy rhinitis more better. So nasal nitric oxide is also considered a key factor for the inflammatory process, and the altered nasal mucosa anatomy leads to increase in the nasal oxide levels. It has been identified in the human upper and lower airway, and severe type of inflammations or blockage of the osteometal complex or edema of the sinus mucosa and even atopic status affect the level of nasal nitric oxide. So the exhaled nitric oxide is used as a non-invasive mediator and a clinical biomarker. So in the differential diagnosis of allergic rhinitis, so many possibilities are there, and it requires a lot of skill on the part of the treating clinician by taking proper history, ordering appropriate investigations, and doing a skin prick test. And nowadays, we also do nasal endoscopy to rule out any mass like nasal polyps or any neoplasm, to be not 100 but 200% sure. So what does the clinical experience say? That how many times, there are certain questions that are here, and I'll be answering them. So coming to the treatment of allergic rhinitis, the mainstay of treatment is allergen avoidance and education of the patient. Whatever you can avoid, that is best, because then you don't need to treat it. Patients need to be educated not from the Google, not from Wikipedia, but by the clinician. So we have dedicated ENT and other specialists who do allergy work. I do, allergy test myself. Even till date, I do the test for all my patients. And depending on the severity, we treat them. So for mild intermittent symptoms, a second generation non-sedating oral or an intranasal antihistaminic usually suffices. So in patients who are having symptoms that are persistent and affecting the quality of life, we start with the intranasal corticosteroid as shown in the middle column. In case the symptoms persist, then we can add either ipratropium or antihistamine, intranasal antihistamine. If the symptoms still persist, then we give subcutaneous or sublingual immunotherapy. Nowadays, sublingual immunotherapy is more desirable because you have to put drops under the tongue for 2 times a week rather than take 2 subcutaneous injections in a doctor's clinic. Coming to the last variety, that is the severe persistent symptoms, we start with intranasal corticosteroid plus oral or intranasal antihistaminic, and we also add an oral leukotriene receptor antagonist, that is montelukast. And if still the symptoms persist, then we go for immunotherapy. So based on the symptom, allergic rhinitis can be treated with an armatorium of drugs. We see what are the main symptoms of the patient and tailor make the prescription for each and every patient. Please remember, no 2 patients of allergic rhinitis can have the same prescription. Sometimes we have to tailor make the molecule that we use, either levocetrizine or fexophenidine, and now the hot favorite, that is bilastine, depending on the patient profile. What are the requirements of the patient, the occupation of the patient, whether the patient drives a vehicle or not. Sometimes that also helps in deciding what drug to use. Steroids are not, the intranasal corticosteroid nasal sprays are not absorbed in the body. So patients who have problem with oral medications, we prefer to give them a nasal spray. And we have both a corticosteroid nasal spray as well as a combination spray where there is corticosteroid plus antihistaminic, intranasal antihistaminic. And now we have a new variety of spray where they have a corticosteroid plus a decongestant also. So the drops that are used for decongesting the nose, xylometazoline, that has come in the spray form. So these are for persistent allergic rhinitis of the moderate to severe variety where obstruction or nasal congestion is the problem. As I said earlier, prolonged use of nasal decongestant can cause rhinitis medicamentosa, but here the dosage is adjusted and the steroid is there to take care of the inflammation. However, it should not be used for more than 6 months at one go. The intranasal corticosteroid sprays can be used safely up to 3 months, 3 years, and including a combination with an intranasal antihistaminic, that is Azelast. Up to 3 years safely I have used in my patients without any problem. Of course, we need to teach them how to use the nasal spray, the direction, the puff amount, and everything else. So coming to the Aria guidelines, recommendation for managing, it is shown in the slide. And this is in a untreated symptomatic patients where the visual analog score is used to decide the treatment modalities. Similarly, we have assessment in the treated symptomatic patient where the visual analog scale is again used, and then we decide what drugs to use and whether to step up or step down the treatment. This is more of a technical slide, which will not be useful in our clinical practice. So what are the commonly used pharmacological interventions for management of allergic rhinitis? Usually we use an oral antihistaminic and a nasal spray. Preferred pharmacological intervention, I start with both and then taper off the oral part. So the decision tree that we follow is from the Aria guidelines. And do you follow Aria guidelines? You know, I have no other guidelines to follow, but we now have the Indian guidelines also from the National ENT Association, of which I am the governing body member. And we have formed the Indian protocols first, which are specific to India, because certain pollen, certain fungus, and the dust mite variety are India specific. So we have formed those guidelines. And in India, we follow that. So coming to the use of a specific molecule called Phexophenidine, it's a highly selective H1 antagonist, non-sedating. It has no cardiotoxicity, and it has very low adverse effect frequency. And advantage is that it is once daily dosing. We can updose it also. Instead of using 120, we can sometimes use 180 till the symptoms come under control and come back to 120. The Phexophenidine Montelukast combination is also available in India, where the combination of a antihistaminic with Montelukast enhances the complementary effects and reduces both the daytime and the nighttime symptoms. Usually, I give my patient this combination after dinner, so that early morning when they rise, they are symptom free and the whole day goes. And whatever little sedation part might be there in 1 in 1,000 patients, that is taken care in the sleep part. So the patient gets up fresh without having any symptoms and can engage in his or her day-to-day activities. The Phexophenidine Montelukast combination versus levocetrizine, the total nasal score symptom has been calculated, and it has been found that Montelukast Phexophenidine was much better and safer than Montelukast levocetrizine combination. This is the SKY study with Bilastine Montelukast, which did not produce the consistent symptoms in the improvement of the symptoms. So the benefit of using Bilastine with Montelukast was, not so much as with Phexophenidine Montelukast. So the acceptable criteria are shown that when the dosage of one ingredient meets the requirement of a defined population group, and the combination has a proven advantage over single compounds administered separately in therapeutic effect, vis-a-vis the safety or the compliance measures. So the Bilastine Montelukast combination did not fit into the criteria as per the SKY study. So comparing the sprays that are available, we can see the picture, and what we now use is Fluticasone Furate compared to Fluticasone Propionate, because Fluticasone Furate has better bioavailability and it is a once daily dosage, and it is much more effective on the symptoms also, that in clinical experience. We can use safely from the age of 3 years, and Mometasone can be used safely after the age of 2 years. So the pediatric safety part is also taken care of now. So why Fluticasone Furate is an ideal intranasal corticosteroid. The symptoms, the factors are shown in the slide. If anybody needs to take a screenshot, please go ahead. So, which antihistamine is considered ideal? Well, there is no one antihistaminic, but based on the data that we have in India, Phexophenidine seems to be the most appropriate choice, because our experience with Bilastine is only for 1 year, whereas for Phexophenidine we have more than 10 years, data which has been analyzed with all the possible tests and has been published also. Is a combination of antihistaminic with a leukotriene receptor antagonist beneficial over monotherapy? Yes, it is. And which intranasal corticosteroid do you prefer for the management? Well, I prefer Fluticasone Furate. So now coming to a bit of immunotherapy, these are the major allergens that we have found. And you can see in the slide, house dust mite is the major allergen across the world, not only in India. So what are the new things that are coming, that are shown in the allergen immunotherapy? Sublingual therapy is already there with us. Now the sublingual tablets are coming for grass and grass pollen and house dust mite. We also have intralymphatic immunotherapy done in only 2 institutes in India. This is still in the research stage. In the biologics, we have omalizumab and dupilumab also now. Omalizumab we use as a last resort weapon. When nothing else works, then we use omalizumab. Chest physicians use it more often for asthma. Of course, the patient education, we have the mask allergy diary, which can be assessed on the smartphone also. And we have newer pharmacotherapy agents coming up. Especially the intranasal, as I said, azelastine fluticasone combination is now available. Azelastine is also available with mometasone, but with fluticasone furate, the combination is to be given once daily. That is the big advantage. So how to deal with failure of pharmacotherapy? That let a ENT surgeon do a proper assessment, including a nasal endoscopy, and if required, a CT scan. The most common refractory symptom is nasal obstruction. So it can be either a nasal septum related problem or a turbinate hypertrophic mucosa problem. And the surgical intervention will reduce the nasal obstruction, which improves the quality of life of the patient. So in surgical treatment, there are many options. The common things that we do are we reduce the turbinate size using coblation or radiofrequency. In intractable sneezing, we need to do posterior nasal neurectomy. And if there is a deviation of the nasal septum, then we do the septum correction, that is septoplasty. Laser is not so frequently used in India because of the cost involved and the technical expertise that is required. Microdebrider assisted turbinate reduction is the most easy way to do that. So here the various options are put up in the slide, starting from the inferior turbinate surgery. Vidian neurectomy now we don't do. Posterior nasal nerve surgery, intractable sneezing, septoplasty if there is a septal deviation, and endoscopic sinus surgery, especially if there is nasal polyposis or chronic sinusitis, along with allergic rhinitis. So the surgical intervention for allergic rhinitis, these are the various references. So what patient profile for using immunotherapy? Well, I feel that out of the 4 phenotypes, mild intermittent does not require immunotherapy. The remaining require immunotherapy. The advantages of immunotherapy being that it not only treats whatever existing allergies you have, but it prevents future allergies, newer allergies from developing. Also, your immune response changes, so your quality of life also changes. And if you compare the cost, it is much, much more cheaper than pharmacotherapy for that entire duration of immunotherapy. Previously, it was for 3 years. Now, the standard immunotherapy protocols are for 5 years in adults and 3 to 4 years in children. We assess at a yearly interval. So if you feel that the immunotherapy is working, you go ahead. If it is not working, then you consider other options. When to use surgical therapy? Well, the answer is there that if pharmacological intervention is not working and the patient consistently complains, मैं नाक से सांस नहीं ले पा रहा हूँ, छींक बंद हो गई है, नाक बहना बंद हो गया है, but I cannot breathe from the nose. I have to breathe with my mouth. That is the time when you do surgery for the nose and relieves the obstruction. What common surgical procedures? DNS correction, turbinate reduction. If sometimes even in adults we find adenoids, it is not that only children have adenoids, even adults can have. So removal of the adenoids also is of great help. And what future research needs to be done? Well, biologics are coming. We are going into molecular allergy level interventions. So we'll have a better understanding, and sometime maybe stem cells can be a treatment of allergic rhinitis rather than taking any drugs. So thank you for your patient hearing, and I'm all ready to take any questions either now or later after my esteemed colleague Dr. Nitin Gupta finishes his talk.
Yeah, thank you, Dr. Vikram Khanna. It was a very excellent talk. And the IMA people have decided that the question answer session will be addressed to both the speakers together, so we can get view of two speakers for every question. So you have to please wait till the end of the session.
Dr. Khanna, we request you to be with us.
Yeah, I'm very much with you. I'm just taking a short coffee break, if you permit me.
It's okay.
Okay. Thanks, Dr. Vikram, and please wait. So we go to the second speaker now, Dr. Nitin Gupta. I'll reintroduce him now. Dr. Nitin Gupta is an alumni of BHU. At the moment, he's in private practice in Mumbai with attachments to Wockhardt Hospital, Global Hospital, Bhatia and Bridge Candy hospitals. He's trained abroad in endoscopic sinus surgery and ear surgery in USA, Italy, and Germany. So, Dr. Nitin Gupta, please take over and start your presentation.
Mic on? Mic on? Am I audible?
Yes.
Hello, good afternoon, everyone.
Yes, Dr. Gupta.
Thank you, Dr. Narukar, for my introduction. And after this wonderful talk by Dr. Vikram, I think he has covered a lot of things. I will just share some points. Basically, this allergic rhinitis is a multi-morbidity. Patient has a lot of other symptoms also, like they have get asthma or food allergy or anaphylaxis sometimes. And this disorder is anatomically related to the other structures like close by structure like sinuses, conjunctiva in eye, from the nasolacrimal duct, the allergy travels. And sometimes in the middle ear effusion, throat infection because of post-nasal drip, and sleep disturbance also happens like snoring and sleep apneas. And these all are because of obstruction. Hello. So basically this sleep obstruction is because of the either adenoid or by the hypertrophic turbinates, which leads to obstruction of the nose, and then there is a apnea or snoring.
So Nitin, can you be a little bit more loud? Your voice is not very...
Okay. Yeah. So allergic rhinitis, another comorbid conditions I was just explaining, that asthma, rhinosinusitis, and other upper airway conditions. And if they are poorly controlled, then they lead to other comorbidities, and because they have the same pathophysiological pathways. And people are likely to suffer the other symptoms along with the nasal allergy like sinusitis, sinus problem, ocular problem, dermatitis, or anaphylaxis sometimes. And if we, as Dr. Narukar told, that it is increasing worldwide. Initially, it was affecting around 40%, but now it is increasing, and even in children, there it is increasing, and it affects our sleep and the quality of life. And that happening, that daytime sleepiness, especially in the meetings, like a lot of people may be sleeping when I'm talking, and so, or especially while driving, sometimes people get sleep, and that's how accident happen. And nocturnal awakening. And as Dr. Vikram has told that how we a patient, how we say that this is a early patient or this is a very advanced patient. We have a visual analog scale, and according to that, we treat our untreated patients. We use first line medication like antihistamine or intranasal corticosteroid or leukotrienes. If the patient is an untreated patient, then we also use this visual analog scale, and we can scale it how much it is what is the at present condition of the patient, and accordingly we start the medication like antihistamines or oral steroid or intranasal steroid. And if patient is better, we can either just maintain the dose or reduce the dose. In case of any persistent exposure, then we have to control the exposure of the allergen and treat it accordingly. So as Dr. Vikram said, allergic rhinitis has an impact on asthma recommendation, but nowadays we are using our own, which is basically very helpful in Indian conditions. But what the IRA recommendation of pharmacotherapy is mild to intermittent allergic rhinitis. We use intranasal or oral antihistamines. An alternative, we can use leukotrienes and prime. And if the mild and persistent, then we can use daily intranasal antihistamines or intranasal corticosteroids. Moderate to severe conditions, we have to add on, as it is shown. So combination of Montelukast and antihistamines, as Dr. Vikram has told, and even the studies also showing that Phexophenidine and Montelukast combination is much superior. It reduces nasal symptoms than other combinations available. And therapeutic efficacy of the combination of antihistamine leukotriene antagonist, if you said better efficacy against composite like rhinorrhea, sneezing, and daytime itchiness. Actually, these symptoms are very well controlled by these medications, and surgery is only needed when there is a blockage of the nose. It is either because of hypertrophic turbinate or adenoids or polyps, and we use multimodalities of treatment like laser, poblator, nasal cautery, or sometimes cold instruments also. It depends on the what type of disease the patient has and what gives the best result. So this, as you can see, that significant reduction of the nasal symptom with Montelukast and Phexophenidine. There is a much better outcome with this combination as compared to the Montelukast levocetrazine. And there is a less sleepy, Phexophenidine is less sedative than levocetrazine, and efficacy-wise also it is much superior. And here it is the same thing that Bilastine Montelukast combination is also good, but as compared to Phexophenidine, Montelukast combination is not that better. It's not better. And Bilastine Montelukast does not produce a consistent symptomatic improvement. There's no benefit of using Bilastine or Montelukast to provide this allergic conjunctivitis, seasonal allergic rhinoconjunctivitis in partially controlled mild to moderate asthma patients. And Phexophenidine Montelukast combination is more effective than the individual therapy. So this combination is superior to if you give only one molecule. And here we are showing the intranasal corticosteroid. There are a lot of molecules like Fluticasone, propionate, mometasone, budesonide, glycinide, and Fluticasone Furate. You can see that It's Fluticasone furoate is having a relative receptor affinity. It's quite high, and its half-life is also quite high. So it's once daily dose, more efficacious, and very less systemic side effects. Intranasal antihistamine and intranasal corticosteroid combinations is also used for the faster symptom control. And if the just one drug is not sufficient, the patient is not getting proper relief, we can add on. What is chronic sinusitis? That is from the infection from the nose, allergen from the nose, it travels to the sinuses, and there is a inflammation in the sinus. And it is also associated with the asthma when it travels downwards towards the lungs. And also because, as the Dr. Narurkar told in the beginning, that once this IgE antibody is attached to the mast cell, and another type of allergen happens, then they release out of progenitors, and that leads to systemic effect of this allergy, all other organs of the body. In chronic rhinosinusitis with the polyposis is also a complication of allergic rhinitis, where there is a defect in the sinonasal epithelial cell barrier, which increases in the exposure of pathognomonic colonized bacteria and dysregulation of the host immune system. This leads to the formation of herniation of a mucosa, which is called polyps, and then it comes from the sinuses into the nose and blocks the nasal passage, and this leads to snoring as well as sleep disorders. The key recommendation for rhinosinusitis, you can see here, the intranasal corticosteroid spray improves the sinus symptom in patient with chronic rhinosinusitis. Nasal irrigation, and for the diagnosis, we do the CT scan plane to see the ostia and any deviated septum or hypertrophic turbinate or any polyps are there. Management of adult and chronic rhinosinusitis without nasal polyps. In this, we use nasal douche as well as nasal corticosteroid spray, and in severe cases, or if we find any defect like hypertrophic turbinate and all, then we can do endoscopic sinus surgery. This is here we are showing that the treatment evidence, what is recommended in adult, depends on the severity, the short term or the long term, what nasal steroids or douche or leukotrienes. And as I told you, the Fluticasone furoate nasal spray is having very good control as well as least side effects in terms of systemic absorption is very less. So there is a very less absorption, and so there is no other systemic effect of this steroid, and its half-life is quite long, so once daily dose is good enough. And if there is along with that, if there is a polyps, then we have to give the treatment, oral steroids also along with the nasal spray, and we follow up the patient with CT scan after 3 to 4 weeks. And in the most of the cases, this either shrink or almost vanish, these polyps. And if it doesn't, then we have to think of this endoscopic sinus surgery after 3 months. And Fluticasone furoate for patient with sinonasal polyps. Topical steroids were more effective on certain nasal polyp phenotype, which is especially have interleukins and this which the secretions of this mediators reduces by this using of this spray. And otitis media is basically starts from the nose, and because of the it happens because of the blockage of eustachian tube. And once the eustachian tube is blocked because of edema, or sometimes because of any deformity, then there is a bacterial biofilm forms, and then the infection travels into the middle ear, and patient get the ear blockage, pain, and deafness. And this is basically seen in the patients with a low socioeconomic status also, and especially in the small kids, we have seen that faulty breastfeeding habits also leads to otitis media with effusion. So here we have explained that how it happens. The same thing, that obstruction, inflammation leads to obstruction of the eustachian tube, which leads to the middle ear fluid collection, and then there is a contamination of this fluid by the sinonasal bacteria or nasopharyngeal bacteria. So once the infection has set, then we need to give antibiotics along with a nasal decongestant and cortical intranasal steroid, so that the eustachian tube get opened up and to clear the bacteria from the secretions. So this is what the picture of adenoid, where you can see in the second picture there is a blocking the nasopharynx, and the tonsil is basically blocking the oropharyngeal area. So adenoid tonsil hypertrophy causes mouth breathing, nasal congestion, hyponasal speech, snoring, obstructive sleep apnea, and chronic sinusitis. Adenoid hypertrophy results in obstruction of nasal passage, eustachian tube, and blocks the mucus clearance. And this causes obstructive sleep apnea associated with the increased expression of various mediator of inflammatory response, the tonsils. So allergic rhinitis is closely associated with obstructive sleep apnea, as I told you before. And in children, the 8% of children without tonsillar hypertrophy had allergic rhinitis, but nearly 30% of children with tonsillar hypertrophy had allergic rhinitis. This is important. Intranasal corticosteroid in adenotonsillar hypertrophy. So the size of this adenoid and tonsil significantly reduces after use for a few weeks this intranasal corticosteroid, especially the Fluticasone Furate. And because the inflammation reduces, the size reduces, and many times the symptoms disappear. And as the child grows, this problem totally solved out, and there's no need of surgery also. But if it is a recurrent and it is not resolving, say after 3 months, then we consider the surgery. And the recommendation is at least 4 times in a year for consecutive 2 to 3 years. Then we consider the surgery. Otherwise, majority of patients do very well with this intranasal corticosteroid. And here is a picture showing that the nasopharynx, especially the oropharynx and hypopharynx, is the area where there is a blockage happens in the adults, but in the children, it's basically the nose and the nasopharynx, from where because of that obstruction, they leads to obstructive sleep apnea. Allergic rhinitis is related to mild to moderate OSA, and non-allergic rhinitis reveal a high correlation with severe OSA in adult. Allergic rhinitis participant range for 16 to 100%. Adequate treatment of allergic rhinitis can reduce the severity of OSA in children. And the treatment is intranasal corticosteroid therapy, which is very effective in obstructive sleep apnea in decreasing the apnea hypopnea index. And it is also effective in the treating the patient, and so that the quality of life become better. Intranasal corticosteroid is effective in reduction of interleukin, which is an inflammatory mediator in the adenoid tissue. They have done this study, the 2 groups, where they have seen patients who are treated with intranasal corticosteroid, that is Fluticasone Furate, the interleukin 6 is reduced. This is they are showing that interleukin 6 is reduced in the children with OSA syndrome. The key highlight is allergic rhinitis is frequently associated with multimorbidities such as chronic rhinosinusitis with nasal polyposis, otitis media, adenocarcinoma, hypertrophy and obstructive sleep apnea. And during the treatment of allergic rhinitis, multimorbidity comorbidities of allergic rhinitis should be considered, like asthma, sinusitis, ocular problems, dermatitis, or anaphylaxis. Second generation oral antihistamine, intranasal like Phexophenidine, and intranasal corticosteroid like Fluticasone Furate is a mainstay of treatment. And in this severe patient, sometimes we use the oral also. And patient who did not respond to intranasal, then we use the combination with the antihistamines, like azilastine. And intranasal corticosteroids such as Fluticasone Furate reduces the symptom of acute and chronic rhinosinusitis. And intranasal corticosteroids and antihistamine significantly reduces the adenoid hypertrophy and subsequently the obstructive sleep apnea, especially in the children. And because they reduce the interleukin 6, and intranasal corticosteroid therapy was effective for obstructive sleep apnea in decreasing the apnea hypopnea index. Thank you very much.
Thank you, Dr. Nitin Gupta. It was an excellent presentation. You described the comorbidities of allergic rhinitis very well and how to tackle all the comorbidities. Nice talk. So now we come to the third part, that is the question answer session. So the questions will be addressed to one speaker and the second speaker can add to the answer if he has something to add to it. Okay. So the first question is addressed to both of you. Is Dr. Vikram Khanna around?
Yes.
Hello, Vikram, are you around?
Want to for a coffee break or something?
Hello, Dr. Vikram Khanna.
He doesn't seem to be there.
Okay, then Dr. Nitin Gupta will address all the questions to you.
Yes, sir. I'll try my best.
Okay, the first few questions are from me, and then the remaining questions are from the delegates. So first question is, what is the percentage of seasonal or perennial allergic rhinitis patients that you have in your clinical practice? What is more?
Generally, so what I have seen, a lot of patients who come to us in our practice are referred patients. So generally I have seen in referred patients, generally they are perennial. And those who come direct, and I have seen they both, and especially in some season, the seasonal comes much more, especially in the rainy season. When the rain starts, a lot of the patients come. So I can say in my practice,
there are acute exacerbations.
More of a perennial rhinitis because the majority of them are referred one. But if you see that Indian Allergic Association guidelines, according to that, the seasonal are more and perennial are not. But it depends on which zone we are living in India.
Okay, so we have a different used zone. To always say that if it is perennial, the allergen is indoor, and if it is seasonal, the allergen is outdoor. Does it still hold true?
Yes.
So when you talk of perennial, you're talking of all indoor allergens mostly.
Indoor, yeah.
Okay, Dr. Vikram Khanna, have you heard the question?
Yes.
Add something to it.
Well, because of the opportunities for work, there is a lot of migration across the country, and even for the study purpose. So in Mumbai, where I am based, I see patients coming from North India, from East India, from South India. So South has the coastal area. So we see, a lot of the seasonal allergies, and even from the North also, there are a lot of seasonal allergies. And patients many times say that, मैं गांव वापस जाता हूँ, या when I go back to my native place, I'm perfectly fine. In Mumbai, I have a problem. Now, the environment of Mumbai is that we are a humid climate. Here, the allergens are different. So, and we have Cocos nucifera, that is the coconut trees along the coast. So, we see both type of patients who say that they are allergic in Mumbai, but not in their gaon, and even the other way around, that they are allergic when they are in their native place, but they feel better when they are here because of certain, especially in the north side where there's a lot of hay dust and certain allergens that are there in that atmosphere. Those plants or those grass or trees are not seen in Mumbai climate.
It's very true, Vikram. What you're telling, change of environment always helps the allergy patient. That is very true. Yeah.
So
basically, for all young females, you should tell them to get married outside Bombay, right? Young females with allergic rhinitis, best treatment is to get married out of Bombay.
Yeah. No, the thing is that, you have raised a very pertinent point that, young unmarried females, whom I treat, we tell them that marry a non-allergic person. Because if both the partners are allergic, the child will definitely have an allergy problem, either rhinitis or asthma. So instead of matching horoscopes, please match your triple H reports. Please match your hemoglobin thing to rule out thalassemia and check your allergy status. Horoscopes are outdated now.
Very true, very true.
So, sir, in correlate to that, we have seen patients who are suffering in India, but when they migrate abroad, like the US, they seem to become symptom-free.
Yeah, yes, so any change of environment, even if they go into a sub-zero temperature, they don't have rhinitis.
Correct.
So basically, the change of environment helps the allergy patient generally. That is what Dr. Vikram was saying.
Right.
Yeah, so the allergens in India are specific to India, especially the outdoor allergens. They are different in the US. And in India, there is a lot of vehicular pollution because of the vehicular traffic and lot of construction. US that way is a far cleaner and organized country. So, it is not a therapeutic option that, we can tell the patient, आपको मुंबई में सर्दी नहीं होती है और जयपुर में होती है, तो आप मुंबई में ही रहो, जयपुर जाओ मत. Yeah, even the other way around, that, best thing if you don't want to be allergic, shift out of Mumbai. It is easier on paper, but practically it is not feasible. So we have to treat them.
Okay, let's go to the second question now. Again, it is addressed to both of you. Let us assume that you're getting a patient of moderate to severe allergic rhinitis. So what is your approach to this patient? Let us skip the history taking and the clinical findings. They are going to be same, and that is known to everybody. So what is your actual clinical approach after history taking and clinical findings? Vikram Khanna, you can start.
Yeah, I follow very simple doctrine. See, I am in private practice. I need the patients to come back to me for further treatment in the form of allergy testing and immunotherapy is required. Well, these patients are all chronic patients. So my first question is, abhi tak kya try kiya hai? Kya use kiya hai? So I know that I don't have to try all that. My options become limited and they become judicious. And because these are, chronic patients who have tried many things, what I do is I put them on a combination nasal spray, that is intranasal corticosteroid with intranasal as well antihistaminic. I also give them a non-sedating, long-acting second generation antihistaminic orally for 10 days. And I give them a short 5-day course of steroid, that is deflazacort. Depending on the body size, the dosage will vary. Now, what this does is it eliminates the symptoms and inspires confidence in the patient that हाँ ये doctor मेरे को ठीक कर सकता है. That is why they come to me for follow-up. Also, in the first visit, they are also counseled for the need of allergy testing and possibility of immunotherapy. In the second visit, I'd also do the nasal endoscopy if there are symptoms of nasal obstruction. and a CT scan is advised if there are sinusitis type of symptoms like headache, purulent nasal discharge, post-nasal drip. So I know at the end of the second consultation what exactly this patient has and what will be my line of treatment vis-a-vis skin prick test, whether the patient may require surgery or not, and whether immunotherapy would be required for that or not.
Okay, Dr. Nitin Gupta, you want to add something, or what is your approach?
Yeah, basically, I also, after examining the patient, I put the patient on a antihistamine and spray, and majority of patient respond very well. Very rarely I need a steroid orally, but if patient is non-diabetic and fit and fine, there is no harm in using a steroid for a short course, as Dr. Vikram said, and it covers very well. And if there is obstructive symptoms and patient has already used a lot of medicine before coming to me, then I advise the endoscopic surgery to relieve the obstruction.
Okay, do you advise surgery so early?
If their patient has already used so many medicines in the past, and which is, and again now complaining of obstruction, that's what it said.
Yeah, so I would like to differ from Nitin here that in such patients, apart from combination spray, long-acting antihistaminic, which is bilastine now, my choice will be bilastine for those obstruction patients because bilastine has a potential for reducing the nasal congestion and obstruction. It is the only antihistaminic which has this property as of today. And giving a steroid, I also give a systemic decongestant. Phenylephrine tablets are available, and tell the patients to take steam inhalations also. I avoid giving decongestant nasal drops because then these patients will land up with rhinitis medicamentosa, which is very difficult to treat. So a short 5-day course of phenylephrine tablets, which is available in India. So that clears off the obstruction. So we know what we are dealing with. And of course, a nasal endoscopy is done as an office procedure in the OPD, where we use 4% xylocaine with copious amount of the decongestant drops that is available, either xylometazoline or oxymetazoline, so that patient feels that yes, the endoscopy was done, the patient sees his own or her own endoscopy, and we show before putting the xylocaine decongestant Vicks, we show, say, see, this is your turbinate size, and after keeping it for exactly 5 to 7 minutes, then we remove and show them, see, this is the difference. Patient breathes, feels the difference, sees the endoscopy, sees the turbinate hypertrophy in the posterior part, the DNS. So when they see their own obstruction, when they feel the relief from the medication, they become more amenable to surgery if it is required. Sometimes adenoids I have removed in a 35-year-old patient also, but they have to see it to believe it. And I believe in transparency. Be honest with your patients. अपने patients को educate करो, उनको सब दिखाओ, उनको सब समझाओ. Don't let them go to some other, non allopathic people and the bogus claims made by homeopaths and Ayurveds. हम ठीक कर देंगे. They cannot do anything for allergic rhinitis. Allergic rhinitis is pure allopathy. Even homeopath says हमारे दवाई से immune status change होता है. No, immunotherapy से change होता है. What you are giving is temporary relief. What we want is a permanent cure, and only allopathy can do that, and the ENT surgeon is best equipped to do that.
Sir, one small question regarding steroid. When you prescribe steroids, the patients sometimes you use your prescriptions again and again, So how do you prevent that?
Sir, I tell the patient that this is a drug that if you repeat, you can get epistaxis. Although ऐसा होता नहीं है, but I tell them. आधी प्रैक्टिस सर आप भी मानेंगे पीडियाट्रिशियंस और कार्डियोलॉजिस्ट की आधी प्रैक्टिस डर से चलती है. तो पेशेंट को थोड़ा डर दिखाएंगे, बोलेंगे इससे नाक से खून आएगा, तो दे डोंट रिपीट. Also, it is written on my prescription, do not repeat this prescription after for the next beyond the next consultation. So that is there. And sir, I use deflazacort. Now deflazacort advantage is that you use it for 5 days, you can stop it, you don't need to taper it.
Correct.
And it is given only for the first 5 days. And I tell the patient, ये steroid है, इससे आपको नुकसान होगा अगर आपने दोबारा लिया तो नाक से खून भी आ सकता है. So they themselves don't take.
Good
and then they start reading about steroids, they see all the side effects. They बोलते अरे बाप रे, इसको तो डॉक्टर ने 5 दिन बोले, सर हमने 3 दिन यूज किया, बहुत अच्छा लग रहा था, वो गूगल पे पड़ा साइड इफेक्ट है तो फिर हमने 2 दिन नहीं खाया. सर ठीक है, अच्छा हुआ नहीं खाया.
Now let's go to the next thing is, typically we used to talk of allergic rhinitis patients as runners or blockers. Of course, there are a lot of patients who are both runners and blockers. So in the old days, surgery was meant for blockers, never meant for runners. But as a rule, there is no separate runner or blocker. We all know they are both runners as well as blockers. When you operate on a patient and he's sneezing and watery discharge is going to persist, do you think your patient is going to be good, or is going to be benefited enough by you, or is going to be happy with your surgical work? What is your take on this, both of you?
Well, I
think-
would say, Nitin, you please go first.
I think if the patient blockage is relieved, then patient, especially the adult patients, are very happy because there's obstructive sleep apnea, snoring, and daytime sleepiness, nocturnal awakening. This all reduces. So patient is very happy. And after that, if something like running nose is left, we can always add on some intranasal sprays or antihistamine to check that. But for the blockage, and if it is not untreated by phenylephrine or nasal decongestants, I feel to operate and let the patient get rid of it. Yes, Vikram, can add on.
So my patients, I clearly tell them that allergy has 2 parts: the sneezing, runny, watery rhinorrhea part, and the obstruction and the congestion part. By medications, we can control the runner part, not the obstruction part. So when they are advised surgery, it is made very clear to them that surgery is to relieve the obstruction, not for sneezing, not for runny nose. In some patients, the runny nose and the sneezing does not stop. So for that also we have a surgery, that is posterior nasal neurectomy, which is much more safer than median neurectomy because of a lot of side effects of median neurectomy. So that is abundant procedure. So patients are counseled right from the beginning that your symptoms will, which symptoms will get relieved by medications, which symptoms will get relieved by surgery. So surgical relief does not mean medical symptom relief also. And allergy is a very unique disease in which relief from symptoms does not mean relief from the disease. Like malaria, you take anti-malarials, that part of malaria is gone. This is
Vikram,
like,
let me present a hypothetical patient to you.
yes, sir.
As we all know, the deviation of the nasal septum is there since they're 18, 19 years of age. After that, the bony growth stops, right?
Correct.
A 35-year-old comes to you.
Hmm.
All these are symptoms of allergic rhinitis and blockage. From 18 to 35 years of age, his blockage has not bothered him. Now the
Correct.
allergy has set in, the blockage has increased.
Correct.
So you control the allergy, blockage is obviously going to be reduced, but the deviation is still there. So in
Yes.
such patients, operating, I think, is not right.
Yes, sir.
I am
So
very selective in operating on an allergy patient. In fact, I try to avoid surgery in an allergy patient because none of the patients are going to be happy after surgery. So
Yes,
surgery should be the
blockage.
last
Sir,
resort, I
yeah.
feel.
sir,
Very
I
good.
follow a very simple routine in my practice. I control their allergic symptoms of sneezing, watering, and congestion. If their blockage still persists and they say we have to breathe with the mouth, or they are snoring and having apnea spells, only then I advise surgery.
Yeah, so the
I am
surgical
very clear in my
intervention
mind.
should be very limited, I feel. Yeah.
Yes, sir. Out of 100 allergy patients, I would not operate more than 5 or 7 of them.
Very true, very true. That is how we should approach the surgical
But if
intervention.
I see adenoids, I will definitely operate.
Okay. All right. The last question from me is to both of you. We all use intranasal corticosteroids for long duration. Okay, suppose we use it for 2 months, 3 months. At the end of 3 months, before you start, and the patient asks you a question, after 3 months, for how long will I be okay, doctor? What is your answer to this?
I will
Nitin, you want
say,
to?
yeah, I will say, see, we cannot cure it, but we can control it. And you are using this spray, and meanwhile you have to we do allergy test. We tell them what these are the allergens, but I tell them this is not a complete thing. You have to see around your environment, what thing triggers you, and try to avoid that. And I tell them do the nasal douche and avoid the allergen, clean your mattress and all those things, bed sheets and pillows and everything.
Doctor,
that,
after all this,
yeah,
and intranasal steroid for 3 months,
yeah,
how long can you guarantee a remission period for that patient?
see, nobody can guarantee anything in this, but if we avoid
What is your answer to patients like this? They are taking care. What you're talking is talked by all patients, all doctors to their patients.
Yeah. But I tell them there is no guarantee, because allergy, what we are giving is only be controllable, cannot be cured. It will be cured by our own immune mechanism. So if any trouble happens, you have to come back again, and we have to again.
He is always going to come back, right? He's always going to suffer.
There's no
Only
guarantee.
question is how long is the remission period after a 3-month or a 6-month course of? How long do you expect a remission period? Vikram?
That depends from person to person. It's very variable. What type of how severe the condition was.
Sir, yes, sir. Thank you, Nitin. Sir, here again, my reply to the patient will depend upon what phenotype of allergic rhinitis that patient belongs to. If it is intermittent or seasonal, I use that during the season and then tell the patient that when the next season starts for that particular allergen, you have to start pre-season prophylaxis. That means almost 3 weeks before the season starts. If it is a pollen or a fungus, you have to restart the nasal spray. I cover the entire season for that particular allergen.
Vikram, we are talking of perennial only here.
Yeah, okay. Now for perennial, my patients remain on a nasal spray for 3 to 6 months, depending whether it is mild or moderate to severe. It is moderate to severe for 6 months. In that 6 months, the patient is made to do all the avoid measures that is practically possible. Humanly possible, the limit is endless, but practically possible. Like dust mite casings are available now, so you can have dust mite covers, use of a vacuum cleaner, get your ACs service regularly. We give them vitamin D, calcium, and prebiotics also in certain cases where the deficiency is found. And they are said that you can remain off an immunotherapy. We counsel them strongly for immunotherapy because that is the only treatment that can guarantee a cure. No nasal spray can give a cure. Nasal spray is for control of symptoms. We have to tell them that symptoms are different, disease is different. If you treat the disease, the symptoms will go away. But if you treat the symptoms, the disease will persist. Avoid measures and immunotherapy. These are the only two modalities of treatment that can guarantee a cure. And this is, hammered in their brains right from the first consultation.
Okay. Now let us go to the questions from the delegates. They are again addressed to both of you. It is role of Jalnidhi, and the second one has asked role of yoga in treating allergic rhinitis.
Yes, sir. All my patients, irrespective of their phenotype, I make them do that, not only to reduce the symptoms of allergic rhinitis, but to improve the quality of life and to maintain a healthier lifestyle. But if the patient has sinusitis, then the Jalnidhi is not used. We make them do alkaline nasal douches to create a acidic pH in the nasal mucosa. Yoga is good. Deep breathing exercise, yoga is good for all of us, irrespective of whether we are allergic or not.
Nitin, you want to add something?
No, what he said is correct. We use that nasal douche is as good as a neti. Neti is also very good. And if there is a sinusitis, they can always add on bicarb and all along with the salt. So that is also very good. And yoga, as they said, anulom vilom, they do breathing from one side and then exhaling from other side, then other way around. That helps a lot. And one more exercise I heard, that Kapal Bhati, they say it's also very good. So these exercises, but I don't train them. I tell them these are really good, but you have to follow a yoga master.
Yes.
Okay.
But
thank you.
also we counsel them that this is not the treatment. These are supplementary or ancillary measures. The mainstay of treatment is different. So, patients should be very clear in their mind that their Jal Nidhi or yoga is just a supplementary measure. वो
Okay,
मेन
another
कोर्स नहीं
question
है,
from
वो
the
डेजर्ट
delegate.
है या स्टार्टर है, वो मेन कोर्स नहीं है.
Okay. So one delegate wants to know that he gets rhinorrhea if he has lack of sleep. He sleeps for only few hours. So what is this rhinorrhea? Is it allergic rhinitis that a delegate wants to know?
Sir, lack of sleep can cause nasal congestion, which in turn leads to intractable snoring, and a simple anti-anxiety drug like etizolam for 2 to 3 weeks takes care of the problem, and he
No, he
has
is
to
not
address.
talking of chronic lack of sleep, Vikram. He's saying that if one night I sleep for only 3-4 hours, then I get a running nose. That is what he means. So if this running nose is allergic or it is non-allergic, that he wants to know.
No, it is an autonomic phenomenon.
So autonomic phenomena, very true. Okay, another question now from the delegate. Can you tell me any red flags to show that allergic rhinitis is progressing to asthma? Nitin?
Allergic rhinitis.
The delegate wants to know whether there are any red flags that he can identify the progress of allergic rhinitis to asthma.
Allergic rhinitis and asthma is a majority of time interrelated because the mechanism is the same. So basically the allergens once enter the respiratory tract, patient get the symptoms of allergic rhinitis as well as the asthma. But if we treat the allergic rhinitis, the medication what is required for the asthma is very much reduced and the symptoms are also very much reduced. I have seen that 80% improvement improvement in asthma if we treat the allergic rhinitis, and sometimes fully cured also, because the entry pathway is the nose only in the asthma also.
Yeah, there are a couple of red flags when there is dry cough, which is sudden onset dry cough which persists, which gets worse especially at night. That is when you start getting that this patient's allergy is going from the upper respiratory tract to the lower respiratory tract. Sometimes the severity of allergy increases and the patient starts to get mildly breathless, especially on exertion. So that is when you do a PFT, see the bronchial responsiveness after bronchodilator, and if it is positive, then you add Montelukast in such patients.
Yeah, I think intermittent wheezing also.
Yeah.
Because when they come to you, they may not have bronchi, but when you ask a leading question, they can tell you that, sometimes they hear their own breathing.
And also, please remember, a stethoscope is very important in each and every allergy clinic. Always auscultate the chest of all your patients because they may have hidden asthma. They may not be able to correlate the asthma history. So, an important tool in a allergy clinic, especially ENTs, is please auscultate the chest.
Can you tell us for how long Montelukast can be given?
Sir, not more than 4 weeks because the US has given black flag signal because of the neuropsychiatric issues, especially in children. So we should avoid fixed dose combinations of antihistaminic with Montelukast. Montelukast is to be used very sparingly. I use Montelukast only if there is a history of asthma either in the patient or in the family, and only for maximum 3 weeks, 20 tablets. That's it. And then stop.
Okay.
I use it also for all patients with allergic cough. I think that is very useful. Because Montelukast basically has a smooth muscle relaxant action. So if there's a combined upper lower respiratory tract allergy or allergic cough, which involves both, the Montelukast is definitely going to work better.
I completely agree with Dr. Narurkar. And if the patient does not have asthma or bronchitis, which is usually the precursor of asthma, don't use Montelukast. It is heavily marketed that a combination will work better. But please remember, the Montelukast receptors are in the lower respiratory tract, not in the upper respiratory tract. They act on the upper respiratory tract because of the nasobronchial reflex, not primarily. There are no Montelukast receptors in the nose and the pharynx. So please use it very sparingly and with lot of caution, and don't use it for more than 4 weeks, especially in children.
The pharma companies are doing aggressive marketing on Montelukast.
Sir, they have their own reasons, but we are clinicians. We have to remain ethical and give the best possible
Let
result.
me tell you, when
Natural.
Montelukast was first introduced as Robilast in India, they
Correct, yes,
conducted an
Robilast.
all India survey with a lot of ENT surgeons from all over. I was part of it. The result was very miserable. Okay.
Yes, sir. So
There is
enough
Montelukast
literature.
in allergic rhinitis. We don't know whether it's antihistamine or the Montelukast that is working well.
No, sir. There is enough literature now across the
but
world, in the
plain
US,
Montelukast
in
is
Europe.
really of no use as such.
Yeah, that Montelukast monotherapy is totally ineffective in allergic rhinitis. There is enough scientific literature, and when it should be added, there are clear guidelines at the Aria level and the Indian guidelines also, of which I was a part. And we are very clear in our mind that Montelukast has to be used very sparingly on, and there are specific indications where to use, how much to use, when to stop, whether to restart or not. It is better to use an oral steroid than use Montelukast. I
So in
would go to
COVID,
that extent and say.
Especially in COVID times, a lot of Montelukast was being used.
Left, right, and center.
Absolutely.
Okay, now the last question from the delegate.
Before Dr. Narurkar puts his last question, I would like to say that allergic rhinitis or persistent cough is not a symptom of Montelukast deficiency in the body. Just like fever is not a indicator of antibiotic deficiency in the body.
Sir,
Most of our
question from my
fevers are
side.
viral in origin, but every time patient you see, they themselves only take antibiotics. And that is causing a lot of antibiotic resistance. Soon we will have Montelukast resistance also, or patient may become resistant to Montelukast just like they became resistant to ciprofloxacin and Septran.
Sir, one question from my side. Where will you put Bilastine in the management of allergic rhinitis, and what dose you recommend? Is it 10 milligram or 20 milligram?
Sir, Bilastine standard dose is 20. There are studies now where you can updose it to 40 and 80 also, but I am very comfortable with 20 milligram. It's a once daily dosage on an empty stomach, which means it has to be given 1 hour before a meal or 2 hours after a meal. It is available in combination with Montelukast. It is a truly non-sedating, long-acting antihistaminic, which fulfills all the criteria of the Aria and other things. It is higher rated than Phexophenidine. Phexophenidine scores 9.5, Bilastine scores 10. The only hitch is that empty stomach thing part. That is the most difficult part. And as yet, the US FDA has not approved Bilastine, and Phexophenidine still remains the drug of choice, especially in pilots. So pilots concentration has to be 100%, and US FDA still approves Phexophenidine. Also, the data of Phexophenidine that we have in India is now 13 years old. Bilastine, we have only, maybe 1.2 years, but Bilastine works very well.
With Bilastine, there is, I think, one issue. You should not follow exactly what the pharma companies tell you. That is the first thing. Because when Bilastine was introduced, it was written in block letters, not to be used below 12 years of age. Today, you have syrup Bilastine available within 6 months. Okay. So you have to be a little careful, I think.
No, sir. 6 years is the limit. I would not use Bilastine below 6 years of age.
Yeah.
At 6 years above, the safety profiles are available in international literature.
But when they were introduced, it was, so it is same as Fluticasone and the Mometazone. Mometazone was the only one which was approved below about 2 years of age.
Correct.
Fluticasone, when it was introduced, it was always about 12 years of age.
Yeah, but
then
sir,
you can use it after 6 years of age.
So that was Fluticasone propionate.
I mean,
now we have Fluticasone Furate. Furate can be used above 3 years.
Yeah, that's true. But then when you know that another molecule is safe right from day one, from 2 years onwards, I think I would stick to that molecule only.
So the advantages of Bilastine over Phexophenidine and Levocetrizine, as I said, we tailor make each and every, prescription. So if it's a lawyer
Absolutely, yeah.
who's having allergic rhinitis, who needs to be, alert and awake all the time, I would not give him levocetrizine. Otherwise, he will sue me only first.
Yeah, but I always
And for a
feel this,
housewife,
that
I would definitely give levocetrizine.
the
वो husband खुश होता है,
antihistaminic,
बोलता है थोड़ा देर इसको शांत रखो, मुझे भी घर में शांति चाहिए.
it is like this. The
Kajal has
antihistaminic which is most effective is maximum sedation,
Yes,
and
yes.
which is least effective has no sedation, like loratadine, I would say.
नहीं.
Sir,
So it is an entire spectrum of antihistaminics.
Sir, I would
Okay,
like to
let's go
share
to the
an
last
interesting
question now
fact
from the
that
delegate.
I
Shall
am
we?
myself a sufferer of allergic rhinitis, and I got my test done by at St. George's Hospital, and I was found allergic to moong dal and cockroach. Being a Punjabi, moong dal was an integral part of our diet at home every second day. I stopped moong dal for 7 years. I did the oral challenge test on myself 3 times. Today, I can eat moong dal daily, but still I follow a cyclic rotatory diet pattern of eating moong dal. So once in 72 hours. So I take moong dal once a week. Cockroach got eliminated by the pest control. What I want to say is that, for me, only CPM works. Levocetrizine does not work. Phexophenidine does not work. Bilastine does not work. Loratadine, desloratadine, cetrizine doesn't work on it. Only CPM works. And if it is intractable, then I have to use Atrax. And Atrax in the dose of 25, not even 10. So
Today
every
also,
body is different.
it's very true that today also a lot of patients come and tell me that for so many years I've been sneezing, I take one Avil or one Incidal, I'm okay. Now it is
Yes,
foolish to tell this patient that how Bilastine is better than Avil what you're taking. He is happy
Correct.
with what he's taking, so let him be. We
They
don't
will not
interfere with those patients like that.
sir, any
So the last
specific-
question now, let's go to
Sir,
that.
sir, one more question. Any specific treatment advice for allergic rhinitis during pregnancy?
Yeah, Vikram.
Sir, in the first trimester, no oral drug. In the second and third trimester, cetrizine can be used. It is safe in pregnancy. In the first trimester, nasal spray is safe in all the 3 trimesters, but only fluticasone, propionate, or mometasone. Fluticasone, Furate should not be used, and the older sprays like budesonide and beclomethasone should be avoided. And azolastine should not be used in pregnancy as part of the nasal spray. Also, in pregnancy, if immunotherapy has been started before the patient got pregnant, that can be continued during pregnancy. It will give good protection to the child. But if an allergic rhinitis patient gets pregnant, don't initiate immunotherapy. That can be initiated after 3 months of delivery, where the patient can limit lactation for the child.
Thank you, sir.
In fact, there is an entity called pregnancy-induced rhinitis. That's a different entity altogether. And the cure for that is delivery.
Dr. Narulkar, you can ask your last question.
Not mine, it is from a delegate only. The delegate wants to know whether when the patient is on immunotherapy, can I give him antihistaminics or combination with Montelukast?
I would request Nitin to answer that.
Yeah, you can carry on. I will say first you give the one drug, and if it doesn't work or if there is obstruction, then you can add on Montelukast.
Sir, on a patient of immunotherapy, I would give antihistaminic first. I would avoid giving Montelukast in patients having on immunotherapy.
I think Vikram, most of the patients of immunotherapy in the initial phase are going to need, because as you are going to give antigen, the Ig level is going to increase initially. These symptoms are going to be there.
Sir, but
most of the patients would require anti-allergic medication.
Sir, I said in my talk also that when immunotherapy is initiated, for the first 6 months, the patient is not only on an oral antihistaminic, but also on a combination nasal spray for the first 6 months.
All the patients are going to need treatment. So
yes, but Montelukast is not to be added.
Yeah.
Oral antihistaminic still not controlled, a combination nasal spray.
That's true.
Montelukast I avoid in patients having immunotherapy. It has no role there.
Very true. So I hope the delegates are happy with the answers you have received from our experts. So we have finished the question answer session now, and IMA people can take over again.
Yeah. Thank you very much, Dr. Narurkar, Dr. Khanna,
very good webinar. Huh?
Dr. Girish
Very good
Raj, expert
webinar.
comments.
Expert comment, very good webinar.
Yes.
No question unanswered.
Yes.
Sir, I hope the answers that we gave are have satisfied the query of the person who has made the inquiry. And if there is any other still, there are unanswered queries or further specification is required.
So
I
I
am from the
remember-
IMA family. I am part of IMA Chembur. I serve IMA Chembur as secretary. So I would be more
Dr.
than happy.
Khanna.
I can share my email and mobile numbers. Dr. Girish Lad, you have them. Please share them with any
Yeah, yeah.
delegate who wants further answers.
Dr.
Or
Khanna, after this lecture, I remember, I think Dr. Narurkar also will agree because we had our HOD as Dr. Gadre. And Dr. Gadre, when he used to teach us SMR, he used to ask, what is SMR? People, some used to say that, submucous resection, this, that. He used to say, no, lad, this is soon may return. So
soon may
similarly, that is what he said, that the moral of the story is that allergic rhinitis, if not treatable completely, at least you can, give them relief in between two attacks. And that is, definitely a take-home message is that at least get a better quality life with modern treatment.
So today,
And
with the
very good-
recent advances that have been made, we can cure allergic rhinitis without the patient having to take a single drug for the rest of his life. But it requires 3 to 5 years of perseverance and patience on part of the patient also.
Yeah, that is it.
Thank you very much, Dr. Narurkar, Dr. Khanna, and Dr. Nitin Gupta. We heard a lot about allergic rhinitis from three topmost ENT specialists from Mumbai. We come to the end of the program. Now I request Dr. Kajal Ahuja, the Assistant Secretary, IMA CGP Mumbai Sub-Faculty, to give vote of thanks.
Good afternoon all. I would like to thank our speakers of today's webinar, namely Dr. D.M. Narurkar, Dr. Vikram Khanna, Dr. Nitin Gupta. I also thank our knowledge partners for the day, Sanofi India Limited. I thank Mr. Dipen Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Awad, President-elect, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Sudhir Patil for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
We
Dr.
thank
Mehta,
our HQ also.
Yes.
So we thank headquarters also for initiating and supporting this program.
Yes.
I think we should
Dr.
thank Bansure.
Dr. Jitesh Mehta and Awad sir, with your permission, can I make a small announcement?
Yes. Go ahead.
Yeah, please.
IMA Chembur branch, in association with IMA Maharashtra State, is going to host the annual Geriatric conference, that is MahaGericon, on the 3rd of April, Sunday. It will be a digital conference from 9 a.m. in the morning up to almost 6 in the evening. We have 12 speakers listed to give a comprehensive coverage of all the geriatric problems that are commonly faced by the patients and how to address them. So I would like to use your platform to invite all the delegates that please register for MahaGericon 22. We have also applied for 2 MMC points. So we promise an academic feast, and all of us are getting old. So we also need to know what our future lies and who are the best people who can handle it and what are the latest modalities. So I would like to invite everyone for MahaGericon.
Dr. Khanna, our president is young. Our president is Rajesh Khanna.
We all are young. And just on a lighter note, because we are at the end of the program, many times I get an inquiry from my patients. Sir, Viagra बहुत महंगा है, Allegra ले ले क्या? So Allegra is the Viagra of allergic rhinitis, I would say.
That's a good one. Okay, we part on a very nice note. Thank you, everyone.
Thank you. I think we
Thank you.
should
So Dr.
thank
Khanna,
Bansode also, who is the
Dr.
man.
Khanna, you can put that particular information on secretary of Maharashtra, all secretary group, hai na?
Yes, yes.
On that
We
you
are
can
doing
put. Then
that.
we will we'll
Yes,
propagate
sir.
it. Don't worry.
And I would
Sure,
request you to share this. We will be sharing the brochure with the registration link and the payment link in a couple of days' time. So please circulate among
problem.
all the IMA Mumbai members.
Yes,
And we
Yes.
will similarly
Sure,
request
sir.
all the branches to do that.
Yes.
No
Thank you.
problem.
Thank you very
Thank
much.
you. Thank you very much.
Okay. Bye bye, everybody.
Piyush?
Yes, sir.
Piyush, close down.